So Leslie, and then I'm going to come back to Matt because I saved all the hard questions for Matt. So the NCCN guidelines were updated on March 11th before the April 29 PRIMA and before the May 8th approvals.
Mm-hmm.
Are they still relevant today? What do you think of the NCCN guidelines? They don't align with FDA approval. How could they? Because they didn't know what it was going to be. But doing HRD testing in the NCCN is a level 2B, HRD testing level 2B. And I get it. If you look at this, the historical past for GOG 218, bevacizumab was a level 2B, and then it got FDA approval, and they said, okay, fine, it's a 2A. It's a little awkward for me because I would hope that the NCCN would look at the data and be independent. Maybe they evolve and get more, change their perspectives. What do you think of the NCCN guidelines today for this upfront management of newly diagnosed advanced ovarian cancer?
Well, I think in general, since you were sort of hitting at the philosophy, the NCCN guidelines are important. They help us build consensus on how we treat our patients. I think they're most important when there's an information void, when there's a data-free zone, to help. And really, I'd say really payers probably use that more than clinicians, to justify, reimbursement for a treatment or access for a patient to a treatment. But now that we have this data from the FDA, I feel like the FDA labels will probably trump the NCCN guidelines, especially from a payer's perspective. And so I see them going back to revise the guidelines. And really, I don't think I've ever seen them really revise the guidelines ahead of an approval in anticipation of an approval based on data that's presented at a meeting and in paper. So really, that's kind of unusual.
The challenge with PALA, thank you for presenting that, by the way, is that, once you start on bevacizumab, you're likely to stop it. You're not to stop it. In other words, I'm sorry. Once you start it, you're going to continue it.
Right.
What the NCCN doesn't do is they don't sort of add guidance, their guidelines, to when to use bevacizumab. How does that make you feel that they don't sort of give information about when to use bevacizumab and when not to add bevacizumab? They just start with that as sort of an a priori conclusion.
It makes me glad. Then I get to choose, based on my patients. So I think they're flexible. They're
supposed to be guidelines, not options. It's not the NCCN options. It's the NCCN guidelines. Go ahead, Matt.
Well, math is an art.
I would have to say that there really are payment options. As to point Leslie's point is, NCCN is a broad group. It's not like this is the best practice at this time when this committee meets. And when the fact they get a 2B recommendation just means not everybody agreed. Less than 50% agreed that this should be a standard at this point. I think if we look around just the members of this call, we don't all agree the value of HRD and what's the best test, when should we do the test. So it doesn't surprise me that it got a 2B recommendation back in January. I think obviously it'll be a revote and they'll say, yes, the FDA says we need this test to combine these two drugs. It'll be a 2A recommendation. So
I think that, I think they're the most valuable in the rare tumors, right? I like the sarcomas and those sorts of things, but for these sorts of things that I see every day, reimbursement. What do you think, Michael, on the NCCN? Then I'm going to move on.
Well, I agree with what was stated. If you go back historically when NCCN was created, Bob Young actually led that whole movement. It was really to get a group of experts outside of NCI and outside the FDA that would provide them with reimbursement. So that's got a lot to do with it. And I think you're right. I think the companion diagnostic will work its way in on the next version. There's no issue about that.